Okay, I wanted to give you a quick resource for spinal cord injury. I'm going to try to keep this less than 10 minutes, but it's not all inclusive. You definitely need to read, but I wanted to just make sure that you understood some concepts and just kind of give you an overview review to give you some help with your study. This is considered like a virtual out-of-class support using Doceri. So spinal cord injury. So you want to classify your injury, right? So the mechanism of injury. Remember we talked about flexion, hyperextension, compression when they jump in a pool and it's called compression and they jump on their, they fall on their head, or and then flexion rotation. That is when the book shows you a picture of someone falling off the horse and the neck is twisted and the body's twisted one way, and then you've got all these torn ligaments. So mechanism of injury, that's how one of the classifications. And then your level of injury. Was it C4? Was it C6? Was it C2? So that's your level of injury. And then you've got your skeletal versus neurologic. Skeletal meaning bone, neuro meaning the lowest segment of the spinal cord with normal sensory and motor function on both sides. So that's your degree of injury, your level of injury, and then your degree of injury. Is it complete? Is it incomplete? Was there a complete transection of the spinal cord? So, or was it incomplete? Do they still have like a mixed loss, like they have some voluntary motor activity? That is all related to the dermatomes, and I've got you a picture over here of your dermatomes. So remember, you've got nerves, you've got spinal nerves that are all connected to the spinal cord, and as you see in this picture, you got a bilateral region of skin that is innervated by pairs of spinal nerves. So that is just a picture for you, and then you've got primary and secondary injury. So primary is the initial injury. They jumped into the pool and fell on their head, or jumped on their head compressed. So your primary injury is what happened, and how it happened. And then your secondary injury, that is when all the swelling and it's ongoing and progressive. So your primary is your initial disruption of axons, and then your secondary is ongoing progressive damage. So you have to initially start care, immediately, to limit further destruction, right? And your extent of injury or your prognosis is most accurate 72 hours after the injury. So this is when you make sure that you've got some spinal stability, that that's why they say don't move the patient when they're injured, because you don't want to prevent further damage. So just keep that in mind as well. So what I want you to do for spinal cord injury is think about ABCs. You want the spine to be stabilized, but you also want to think about ABCs: airway, breathing, circulation. If they, depending on level of injury, are they going to have trouble breathing? Is it going to make them stop breathing? And then, of course, spine stabilization. Consider what the spine does. There's nerves, neurons, ligaments, bones, all involved. Your spine holds you upright. Your spine does so much. So it's all of this is involved in such a small space. So you're thinking about swelling and all the different dermatomes and nerves throughout the body that can be involved with a spinal cord injury. So keep that in mind. So all body systems could potentially be affected. And I just got a picture of a brace there. So I highlighted here your cervical first 4 vertebrae, because usually if you have a greater than C4 injury, your patient could possibly end up on a mechanical ventilator. Now, this is if they're a complete injury, a complete spinal cord injury, they most likely will end up on a ventilator. And then anything above T6, so the higher you get, the more problems you run into. And you can have trouble C4 and below. You can have even just trouble with the intercostals and weakened muscles and frequent, reoccurring pneumonia just because of the nerve involvement. So keep that in mind, that respiratory and having them cough, deep breathe, incident spirometer is very important. Just like any time. You want to make sure that you're assessing breath sounds, that they may need CPT, to help break up some of the buildup in their lungs. So keep that in mind as well. So greater than T6, that affects the sympathetic nervous system, right? So you want to think problems that could occur with a greater than T6 injury. And I highlighted it there. You want to think respiratory issues, secondary to the dermatomes and nerves involved. You want to think possible neurogenic shock. And you also want to think autonomic dysreflexia, right? Because you want to, you have your sympathetic nervous signal, your sympathetic nervous system cannot get the signal through. So it kicks in, but you have inability of the vessels to constrict. So you have decreased venous return, decreased preload, decreased stroke volume, decreased cardiac output. So think about that. Think about greater than T6. You're at increased risk for autonomic dysreflexia. So there's all kinds of nursing interventions that you got to think about, such as TED hose, tilt beds, SCDs, just to help get some venous return back. They may have to, if they're in neurogenic shock, you may have to give them fluids. You may have to give them vasopressin, norepi, dopamine, any of those to help shunt some of that blood back to the major organs. Get some increase your MAP so that can perfuse the organs in the spinal cord, because you are wanting to prevent further injury, right? Further injury to the patient and to the spine. So just remember, when they're in neurogenic shock, they don't necessarily have a cell problem, or their blood is just kind of pooling in the pipes. So you just got to replace that fluid and try to get their blood pressure up. But you don't want them to go into overload either, so you have to make sure you're assessing your patient. Of course, you want to think about urinary. You don't want an over-distended bladder, so you need to make sure that you are assessing that. You may have to intermittently cath them. They may need a suprapubic catheter if they have a neurogenic bladder. So you want to think about that as well. Urinary retention can cause UTI, and then also urinary retention can exacerbate and cause this autonomic dysreflexia, right? So making sure that you're caring for the urinary system is vital. All the systems. You want to consider metabolic, you want to consider skin, you want to consider the GI tract, peripheral vascular, you want to prevent DVTs. And you want to consider psychosocial. Also, when there's a higher injury, you want to consider that they're higher risk for increased poikilothermism. And you may have to monitor their environment, monitor body temperature, don't overload them with blankets, and don't unduly expose them, because what is the problem here? They have an inability to sweat or shiver below the level of injury, so make sure that you are monitoring their temperature, and that's really important. And that is usually also the degree depends on the level of injury. So it's really more common with cervical injury and above T6. So keep that in mind as well. Nutrition is huge. You may have to consider they may need a PEG tube because a lot of patients lose weight. And anorexia is their way of control. They don't have much control. They've lost mobility. They've lost their identity, and if they were, career people, so they want to control their food, and you have to make sure you address that and ways that you can help them because they want to be in control. So you may have to give them things they want to eat. And come up, with a plan. You've got to involve the patient in this plan of care. They've got to take ownership and feel like they are part of it, or they just will not be compliant. So a huge factor in this is making the patient and the family part of the plan of care. Know your levels of injury. I've got this great picture here that shows you the different levels of injury. I would know these. We already talked about C4, C6, T6, and definitely L1 can be paraplegia. So I would be familiar with all your levels of injury. Don't forget about the dermatomes and how they affect. Because even though, say, you could have a person that has a C5 injury or C6 injury, and if you see the dermatomes, that goes all the way down to the C6 goes all the way down to the thumb. They could have numbness and paresthesia in their thumb. So keep that in mind, that it's not, the dermatomes go outward. It's not just going to be a localized injury at the neck due to the nerves that we have throughout our body. So keep that in mind, that just because we have you also got to think about the organs that are near the injury. So if you're looking at the dermatomes, think about where the bladder is. So you might have a T10 injury and you still have problems with your bladder, or you might have a T1 injury and you have trouble with your lungs. So just keep that in mind, that those dermatomes do make a big difference in your how you're affected by the injury. So as far as planning, you want your patient to return home or to a long-term care facility or to the community with optimal level of functioning. And definitely you have to have your family and your patient involved and owning their plan of care and a part of it. And adequate ventilation, whatever you need to do, incentive spirometer, cough and deep breathe, CPT, you definitely, airways, huge. You don't want them to have skin breakdown, so that's covered, not only turning the patient, but also nutrition. So you want to keep that in mind, and you just don't want any complications of mobility. So passive range of motion if they can't move, and active range of motion if they can. Those are all very vital. So keep that in mind. And like I said, this is not all inclusive. It doesn't have everything you need to know in it. But I wanted you to just be able to focus and kind of have an overview. Definitely read your book, and I hope that this helps, and I will see you soon.